association of all 107 hospitals throughout Virginia who have a shared vision of, through the power of collaboration, we will be the recognized driving force behind making Virginia the healthiest state in the nation by 2020. Last summer, the Board of Directors convened and developed a strategic plan for the next 5 years. And in regards to quality and safety, they identified 4 areas of improvement that they wanted all Virginia hospitals to work on together. First, hospital readmissions. Secondly, healthcare acquired infections with a specific focus on C. difficile. Improving patient as measured by HCAHPS, and then reducing serious safety events as part of a larger initiative to help all Virginia hospitals become highly reliable organizations. Today's webinar, of course, is part of our collective work around hospital readmissions, which we hope to reduce by 20% by 2020, specifically looking at hospital-wide readmissions, post-acute readmissions, and total hip, total knee readmissions. Next slide. Our work around readmissions is being done under the rubric of Omens the Hub, a statewide initiative to reduce hospital readmissions. This collective work is scheduled to go until November of 2018. So today's webinar represents the end of phase 1 of that work. And for those of you that have been involved since June, you know that we have focused on engaging our post-acute providers, working with other partners such as VHQC, now known as HQI, for cross-continuum work, continuing our work with the AAAs on incorporating community-based care, and understanding how to effectively use and interpret data that's provided by the VHHA, HQI, and other sources. This collaborative work will continue through November of 2018. A brief summary of what we've done so far this year. We started in June with a high-level review of our high-leverage strategies that would guide our work for the next 18 months. Dr. Boutwell, who served as our advisor and continues to serve as our advisor, reviewed data and measurement strategies in August. September, we focused specifically on reducing post-acute readmissions. In October, we looked at strategies regarding improving care for high utilizer patients, now referred to as multi-visit patients. And then last month, we were fortunate to have Dr. Boutwell here in Virginia with us for an all-day learning session that was actually sold out, and we regret that we were not able to accommodate everyone who wanted to attend that event, but we are in discussions with Dr. Boutwell to have a return to Virginia next year. And then again today, our last webinar is focusing on how you can incorporate what you've heard so far this year and articulate your own specific strategy for reducing readmission. And we will hear from a couple of our Virginia hospitals regarding how they are articulating their readmission reduction strategy at their facility. As we look forward to next year, we will not be necessarily adding new content, but we will begin what we're referring to as our deep dive series, in which we will delve further into the high leverage strategies that were introduced during the first portion of this work together. We will continue with statewide webinars, and our plan is to also supplement that with opportunities for hospitals to have one-on-one consultations with Dr. Boutwell. We will have more information about that as we move into our webinars for next year, but just know that we will continue these statewide conversations and provide the opportunity for one-on-one deep dives with our advisor, Dr. Boutwell. So at this time, I will go ahead and turn the webinar over to Dr. Boutwell, who will lead us through today's content and will facilitate our discussions with our guest presenters from Riverside Health System and from Carilion Clinic. Dr. Botwell?
Great. Good morning, and thank you, Abraham, and thanks for joining everybody. Let me just get the slides up here. Great. So, as Abraham outlined, we've covered a lot of hopefully new and interesting and helpful content for your readmission reduction work over the past several months. And as this is the end of the year, the holiday season, it seems appropriate to reflect on where we stand and perhaps take this opportunity to make some resolutions for next year. And so in that spirit, we thought we would build on a very lively discussion we had at the November in-person learning session, where we talked about ways, tools and ways to inventory what readmission reduction related efforts are going on across your organization and bring those together on a strategic map or a driver diagram. And so we learned in that session, again, sampling of folks who were able to attend, that while some organizations have such a visual, use a driver diagram or a strategic map of some sort, not everybody has pulled together the fullness of their readmission reduction related efforts to really look at it in its sum total. So today we'd like to talk to you about what's the value of doing that, and some concepts that I'll draw from the newly released Agency for Healthcare Research and Quality Guide on Reducing Readmissions. And then we're very, very fortunate to have some examples from our colleagues in Virginia, Carilion Clinic and Riverside Health System, to share the strategic maps and driver diagrams that they have regarding their readmission reduction efforts, and really paint a picture for you of the content and the usefulness of such a tool. We'll wrap up with an invitation for you to take some specific action steps to harvest what is going on at your organization, pull it together in a strategic way, and really look toward your New Year's planning using a tool like this. So, why do this work? You and your teams and the various committees and the various programs across your organization, you're busy every day doing the work of serving patients, trying your best to bend that trend on readmissions for your organization. One thing that we found, or one thing that I have learned from working with busy hospitals, whether large or small, teaching or community, and everything in between, is that it's really hard to keep up with all of the changes and the good work that's happening even within your own organization. And so, so I'm going to, as I said, for those of you who weren't at the in-person learning session, I'm going to reference a guide that my colleagues and I just published on behalf of the Agency for Healthcare Research and Quality. You can see it here. We call it Designing and Delivering Whole Person Transitional Care. And the shorthand, the guide, we call the guide the Aspire Guide. And it's because based on our work nationally with hospitals that are really trying to reduce all payer readmissions, just like the goal here in Omens the Hub, we learned that that hospitals with success have organized their work through two primary drivers. Okay, so if this is a driver diagram, this is our Aspire Guide's driver diagram, and so on the left hand box you can see the big goal is to reduce readmissions, and we have observed and learned and recommend that in order to successfully reduce readmissions, We need to pay equal attention to a good data-informed design of our efforts, and that's the analysis box, as well as take the actions on the front lines and with our cross-setting partners and with our dedicated target population teams at the front lines of care. And so this is a little bit different than other approaches that you may have seen in terms of toolkits that might focus, for example, on the hospital-based care transitions processes. In this model, hospital-based process improvement would actually fit into that I box in the ASPIRE acronym, the Improving Whole Person Transitional Care Processes for All. And so what we've learned and what I'm inviting you to do here at the end of phase 1 of our Omens the Hub initiative is take a moment to review the extent to which you've done or you would like to refresh the work in this analysis driver to make sure you have a data-informed, strategically oriented design around your readmission reduction efforts, and then harvest and create a strategic map or a driver diagram to reflect all of the actions that not only your team or the committees that you're aware of are doing, but the sum total of the complementary efforts that are undoubtedly happening, across your organization. So just to flesh this out a little bit more, you'll then see we developed our 6 secondary drivers, which are action domains, according to this ASPIRE acronym. So, so in the analysis component, we have 3 chapters in the guide about analyzing and using your own data, inventorying and surveying what is happening right now in your organization and across your community, post-acute and community-based providers and agencies. Who's doing what that all is aligned with your goal of reducing readmissions? Survey that, and then using your data, your root cause analysis insights, the existing resources that exist within your organization and in your community, then move into P, plan a multifaceted portfolio of strategies to really bring all these pieces together so that instead of a bunch of disconnected but complementary activities, you're creating some purposeful alignment in order to drive results. Moving into the action component, I've learned over my years of studying successful hospitals that every hospital that has success in reducing readmissions overall has worked in at least 3 complementary domains. Domain number 1 is improving hospital-based transitional care practices for all patients, right? This is the Project RED, the Project Boost, the elevating what we do for our patients while they're here and immediately after they leave, to ensure that what we do is reliable, high quality, and consistent, and addressing the transitional care needs of all the patients who come to our hospital for care. The second domain is to reach out and collaborate with cross-continuum providers. And we've talked, that's really at the heart of all of our focus areas here in Omens the Hub. We need to purposefully collaborate with our post-acute care providers, with our community-based behavioral health and social service providers for our multi-visit patients, and with our rehab and home-based rehabilitation providers for our hip and knee readmission focus areas. So not only do we need to do well by the patient while they're here with us, but the R, the reach out domain, really reflects all of the actions that we need to lead and manage in order to have successful cross-continuum care. And then finally, the E reflects much of what I heard hospitals in Virginia and as well as across the country are doing delivering specialized, dedicated, additional services for patients that you have determined are at highest risk of readmission. This might be a dedicated heart failure program. This might be a dedicated, outreach and navigation program for people who need linkage to services after they leave the hospital. But most hospitals that get success have work in these 3 domains represented in the ASPIRE acronym. So also, with regard to the ASPIRE Toolkit, ASPIRE Guide, there are 13 tools that I will be referencing with regard to articulating your strategy that you may want to download and take a look at. I recognize that any tool is but a mere suggestion, and what I'm hoping is that you might download and print out the tool and then draw some sort of inspiration from it and incorporate the best ideas that are helpful to you in your own workflows. But these tools 3 through 7 that are bolded here on the screen are ones that I think are particularly germane to articulating your readmission reduction strategy and putting it together in a driver diagram or some other visual strategic map. And again, the links are here at the bottom. This is live and on the ARC website, free for download right now. Okay. So to get started on articulating your strategy, I do recommend that you take a moment. It does not have to be laborious and cumbersome, but you take a moment, maybe with your readmission reduction team, or if you have a cross-continuum team, or if working with Carla and the former VHQP organization, reach out to your cross-continuum coalition and take a moment to say, you know what, we want to put everything on, we want to harvest all of the complementary readmission reduction activities that are going on in our organization and within our cross-continuum regional partnerships, and take a moment to inventory what is available to you. Because in the course of articulating your strategy, what you may find is what's going on that's under your direct management, but there may be work going on. In fact, I'm almost positive there's work going on in the bundled payments, or with some ACO, or with the Elder Services Agency, the AAA, or through your post-acute network relationships, etc. That is really all part of the organization-wide readmission reduction strategy. So what you're hearing from me is an invitation to maybe think about whether or not you have walls between, quote, readmission reduction and, quote, bundled payment teams, or, quote, the ACO team, or the person who runs the post-acute network, or whatever the case may be. And make sure that if any silos or disconnects are in existence, well, then this is a great opportunity to say, hey, we want to come one, come all. We want to get all of this on the same map, because we're all working toward the same ultimate aim. Okay, so then once you inventory, the next step is that inventory is a ready-made gap analysis. And so once you look at the inventory, don't only look for what does exist, but just, again, take a moment, and this is maybe a 1-hour meeting or less, 20 minutes at your desk, to look at the inventory and analyze, well, what's in place for what patients and what gaps are there. So, for example, if you've decided that a certain set of target populations are at high risk of readmission, look at your inventory and say, are we doing everything that we know we need to do for those target population patients in order to ensure that we're minimizing their 30-day readmission risk? Or think about the target populations that we're inviting you to consider through Omens the Hub. Are we specifically working with post-acute care? Are we specifically working on multi-visit patients? Are we specifically working with our hip and knee replacement patients in order to minimize their risks? Next is to use the inventory and the gap analysis that you do, that you've done through bullet point number 1 and number 2, to map out what's your existing strategies, what is in place today. And again, for some organizations, this may be very straightforward. For other organizations, this may be an extensive multi-page undertaking. Whatever it is for you, look at what currently exists and decide whether or not there are important gaps to fill, or whether you'd like to focus on improving the reliable and consistent implementation of what already does exist. And I'll tell you, those are two very powerful options. They're not mutually exclusive, of course, but filling gaps is a entire domain of improvement opportunities in and of itself, and equal, if not every bit as hard, as we all here in process improvement know, is getting reliable, consistent, effective implementation of what you already have in place is also very, very worthwhile if that's the direction you decide to go. Okay, so I'm going to share with you the two hospital inventory, or the two inventory tools that are in this Aspire toolkit. And of course, you can't read it here on the screen, but just to give you a sense that this is, something that I could imagine you might bring to your next, cross-continuum meeting or readmission committee meeting, or you may circulate it with some managers and directors across your organization. And really, what we're doing is we're trying to prompt a consideration of not only what exists, we'll say, from a clinical service perspective. Okay, we have transition of care nurses. That would be pretty obvious, hard to miss. But this tool prompts maybe some of the internal assets that might not be as visible, but are nonetheless part of a robust, or could be contributing to your robust efforts to reduce readmissions. So an example would be considering the assets and the resources in your HIT department. So is there a flag? Is there automatic notification when high-risk patients come back in, et cetera? And you can see some of the check boxes we have. And it's, again, just to prompt some thinking, what's going on across the organization in different departments that might not directly represent a member of my readmission team today. So again, look broadly, try to identify all the assets that might contribute to readmission reduction efforts, and then of course not only identify what's in place, but think about, are we as coordinated as we should be? Is there any duplication that might be happening? Is there any, are there any gaps? And as you do this work, ask yourself, which groups of patients is this benefiting? And which specific colleagues in my organization are leading this work? And again, to give you a sense of, do we need to broaden the readmission reduction team umbrella, or do we need to have some specific communication and coordination efforts to make sure that something that's happening, and I'll just give an example for the bundles, is also happening for the quote readmission team. And again, I give these examples because I've heard of these challenges in organizations across the country. Okay, the next tool, very similar, and again, meant to just stimulate and broaden, a general search and consideration of what exists in the community. I tell you, there isn't a community I've worked in where people say we have everything we need, right? We have all the resources we could ever want. The first instinct is to always say, gee, we are resource constrained. And while that's true, you may just consider my perspective that I've learned we can always find a resource in the community that we were unaware of. And so in the spirit, really in the best spirit of lean and reducing waste, why don't we start with asking what does exist? And rather than rushing to what doesn't exist, I would invite 2017 for you to be about optimizing the linkage and the connection and the collaboration with what does exist. And it's very, very important to articulate the gaps. Of course, you've heard that from me. But first, start with what does exist. And just from the visual impact of this community inventory tool, you can see that this is from the field. This is from hospitals, hospital teams, community partners, just like all of you on the phone. And there's no shortage of opportunities to better coordinate with typical community-based providers, agencies, social services, etc. And so, again, this is not meant to be particularly laborious. There's probably someone in your hospital, and even better if there's also someone from your community-based cross-continuum team, or if you're working in a coalition, or if you're working, with an agency that has has deep connections to the community. Invite them to fill this out partially for you, as well as asking your hospital-based, readmission champion, or your director of case management, or your director of social work to fill this in from your perspective. So, again, a great opportunity here at the end of the year to say, let's just be sure we know what does exist in the community, and then, of course, you ask the questions here at the bottom of the slide. Are we optimizing what's already available? And really important, and it's a great opportunity, I've seen hospitals really flourish with this, is linking to these services as easy as it needs to be. We are really, really good in the hospital in connecting people to post-acute care, right, to getting them screened and accepted to skilled nursing or to home health. And so think about how, quote, easy that process is. And is it just as easy to get someone connected to options counseling in the aging services in the AAA, or to the appropriate recovery supports through your local behavioral health agencies, or whatever the case may be? Try to think about creating pathways, referral pathways, so that each and every member of your frontline staff finds it just as easy to connect to, quote, community or social services as it is to connect a patient to post-acute care. Okay, so special, a special topic, I guess, that we're going to explore more in February's webinar that we'll announce the date and time for that forthcoming. But in February, we're really excited because we're going to talk to Medicaid and Virginia Managed Care Organization about the work that managed care organizations do in terms of complex case management, disease management, coordination of services, etc. And I will say that this is a topic that I am very optimistic that it's really worth some effort to build bridges with managed care organizations. And having said that, I've personally facilitated enough meetings to know that there are two tips I would give. Number one is, when we think about collaborating or reaching out to the managed care organizations, it's not the usual utilization review person, of course, that we're trying to connect with, right? So hospitals have a relationship with MCOs or health plans that is very much in that utilization review justification zone. That's an important zone of work, but that's not the zone I'm talking about. I'm inviting us to figure out, and it might not always be obvious, who is the right contact in the MCO who works with their usually high cost, high risk patient population. And to figure that out does take a little bit of work, but I have, through my work with the Agency for Healthcare Research and Quality, I've been fortunate to network with many of the medical directors of the largest health plans across the country. And really what the medical directors say is if a hospital really wants to collaborate and doesn't know who to reach out to, then reach out to the medical director and we will facilitate the right connection. And so anyway, we're going to talk about this more in February, but suffice it to say, in the spirit of who's contributing and who's invested in reducing readmissions, we of course want to remember that the payers foot the bill, and so they also have some investment here. And then finally, this was just for fun, really. In preparation for this webinar, I did just a 10-minute search on who else, if you will, quote, foots the bill for readmissions in Virginia. And other accountable providers, of course, hospitals in Virginia are accountable because we have readmission penalties and we are exposed to the value-based payment incentives and penalties through that program. And many of your hospitals run Model 2 bundled payment programs. But remember, there are also MSSP ACOs who have a vested interest in reducing readmissions for their patients, as well as Model 3 bundled payment participants, and that would be the post-acute care initiator of a 90-day bundle. And so again, this I found in 10 minutes of a Google search, and it's just a reminder that when you sit down and do a little bit of an inventory and you think, who's on my team, who's on my side, am I working with everybody who has an interest locally in reducing readmissions? Make sure you get all that on the map. And so once you do, this is just, I won't walk through this, but you can use this slide just for a thought exercise, and look at what you've learned from your harvesting efforts, and ask yourself some questions about what does exist and whether or not you, as a leader of readmission work at your hospital, would like to modify or intensify work in any particular strategic domain. With that information, you might then draft out a driver diagram. And a driver diagram has, comes from my origins at the Institute for Healthcare Improvement, and subsequently was shared and has become a common tool at CMS. And I really find it a very helpful visual. This is again from the guide book that I referenced, and would help you just think about how to organize all of that information that you're thinking about from your inventory and your gap analysis into these concepts around primary driver and secondary driver. So just briefly, and then we're going to hear real world examples, which is always the best. Just briefly, at the far left is the guiding aim statement. And again, we had a great discussion at the November learning session about different organizations' readmission aim statement. And it's really, really important. I cannot emphasize enough how important it is to write the aim statement down. Are we reducing readmissions by 20%? Are we reducing readmissions for the hospital? Literally for the hospital. And by how much? 20%, 10%, 20%? By when? So what are we doing, for whom, by how much, and by when are the ingredients of a specific aim statement. Some hospitals are focused on minimizing readmission penalties. And so that would be a very specific aim statement. If that would be more like our aim is to reduce, well, you could say our aim is to reduce Medicare readmission penalties, you know, by 2018, by 20% by 18, or eliminate, if possible, or reduce by half, whatever the case may be, readmission penalties by 2018. Well, then you know who your target population is, Medicare fee-for-service, and it would be those discharge conditions, and you know exactly how much, and you then have to study how the penalty program works, so you understand how long it will take you in order to change the penalties that you're exposed to. Or you could take a little bit more of an operationally friendly aim statement to say we'd like to reduce readmissions for our high-risk patients by 20% by 2018. And then, of course, you need to define who are your high-risk groups. We, in Omens the Hub, might suggest high-risk groups include patients discharged to post-acute care and multi-visit patients, in addition to any other target population patients that you've already identified. Okay, so the aim statement it should not be glossed over and is a very important grounding principle, because really it's from that aim statement that then you think, now that I know who I'm focused on and how much I need to improve the outcome by, am I doing everything? Is this strategy complete? And if it is complete, are we executing it reliably? And are we continuously improving the effectiveness of the strategy that we have? The drivers, some people call them strategies, whereas the secondary drivers, some people call them tactics. I think of the drivers as the organizing buckets of all of the activities and tactics that one is implementing on the far right-hand side. So it's kind of a conceptual bucket of if we're doing disease-specific management for heart failure, COPD, even hip and knee rehab, etc., then maybe those 3 different activities are secondary drivers for an overarching primary driver that says we are going to deliver disease or condition-specific cross-setting management for 30 days. So again, we're going to hear some great examples from our colleagues right now. So first, I'd like to turn the floor over to our colleagues John Schumacher and Paulo Quinn from Carilion Clinic, and they'll share with us their strategy map for readmissions. Paul and John, I'll turn it over to you.
Well, thank you very much. If you would advance, and maybe just go ahead and go to the strategy map.
Sure.
And I hope everyone can see the text okay. This is a tool, it's similar to, I think, the driver diagram, but maybe has some steps that are a little more explicitly laid out. And it's a tool that one of my former coworkers came across a few years back, and I wish I knew where it originated from so I could give proper credit, but we just call it the 5-level strategy map. And at the top, you'll see the first level is what's the strategic outcome that you're trying to achieve. You come down another level, and that's level 2. What are the business outcomes that support the strategic outcome? Come down to level 3, what are the project outcomes that support the business outcomes? Level 4 are then the deliverables that support the projects, and then 5 are the tasks that support the deliverables. So that's kind of the general format you see. And we had filled this out relative to the initiative to reduce hip and knee readmissions, 30-day readmissions. So I'm going to turn it over to John, who is actually the PI consultant that was assigned to the project, and let him explain the different steps.
All right, so the very first step at a strategic level, we're wanting to reduce or eliminate the reimbursement penalties for our 30-day hip and knee readmissions. and we calculated this out to be roughly $630,000 a year that we're getting or we're not getting in reimbursements. So down to the project outcomes, level 3, we did some chart reviews of a year's worth of readmissions and kind of found some of these things to be reoccurring. And the first one was the bowel management protocols from a certain facility, specific to one. We had 6 of our 38 readmissions come from one skilled nursing facility. So we spoke with their medical director, and they had agreed to standardize the bowel management protocols at their facility and get them in line with what our ortho physicians had put in place as their bowel management protocol. And then another thing that we found was that when patients are coming through our emergency department, the ortho surgeons were actually only consulted on about a third of those patients. So we wanted to develop some sort of reminder whenever these patients have come in after having a surgery within the past 30 days. And this is actually more overarching, not just specific to hip and knee procedures, but basically this best practice alert fires when the ED physician wants to.
And just to clarify, we're looking at the second project outcome now.
Yeah, sorry. So basically, we put in this best practice alert to fire when the ED physician is requesting a bed for an inpatient admission. So this reminder, it essentially functions as a reminder to say, hey, this patient had a surgery in the past 30 days. Do you think it would be good to consult with the surgeon that performed this procedure? So on to the third outcome, we were basically looking at trying to increase the ability for these consults to occur. So it is related to the reminder for the ED physician to consult the ortho physician, but basically there was really no process for the specific to hip and knee procedures for consulting after hours. So we wanted to increase that the ability to communicate between the ortho surgeon and the ED physician, and maybe even the admitting provider. So getting that communication in place we thought was critical. Then on to the fourth one, we wanted to make sure that the clinical coordinator for the ortho program had a little bit more capacity to do these deep dives looking into the root causes for these 30-day readmissions. So essentially we wanted to free her up to do these chart reviews by automating some of the reports that we could. Because right now she's essentially doing it manually. So anytime she finds a readmission through our electronic medical record, she's just going through and plugging in all this information into Excel and actually a handwritten sheet and then into Excel and doing it all manually. So we thought if we could automate that, that would help free her up to do a little bit more of the root cause analysis. And then lastly, for the project outcomes, we wanted to, related to that, provide some high-level data for the ortho surgeons. So for these 30-day readmissions, just providing, what is your readmission rate this month? Maybe provide that by the facility, like their discharge location, where they went, and also the provider, who was the surgeon who performed the procedure, what are their individual readmission rates. So they can look at that stuff and look for some higher level trends to then maybe point them in a direction for their deeper dive root cause analysis when they're doing the chart reviews. So if we wanted to continue on down to levels 4 and 5 as examples for the standardization of the bowel management protocols at the SNFs, basically for our level 4 deliverables, we wanted to make sure that the protocol was documented, and then that the medical director actually, going down to the task level, had to make sure that the medical director agreed to follow these existing protocols.
Yeah, and I should probably just point out here, if you're going to use one of these 5-level strategy maps, the expectation isn't that you sit down and in the same hour that you list your strategy at the top, you have all of your tasks listed at the bottom as well. It's a bit of, as John mentioned, when we got down to the project outcomes, they did chart reviews for a year's worth of readmissions to sort of determine what those things are. So the strategy map is a bit of a living tool, if you will, dynamic tool that you update as you go along. The nice thing well, one of the things that I like about it is as you're doing the work, the mapping, it's easy to relate it back to why are we doing this, right? So it helps to keep you sort of on track within scope, and you can see that you're aligned to what is that higher level strategic outcome that you're trying to achieve. In this particular example, although we focused on hip and knee readmissions, for those that were, I believe it was in the November 15th session in Richmond, as Dr. Botwell had mentioned, it's, organizations that are more successful are process focused as opposed to being disease specific focused. So even if you look at what we have in our project outcomes, many of these things translate at a process level. So when we say one of the issues is the very first one in project outcomes, standardization of bowel management protocols, that could certainly be related to any patient that you're discharging, one with pain management issues. So making sure that the bowels are functioning properly when they leave the facility, or even go to the second reminder for ED physician to consult with the surgeon. You may remove surgeon and say whoever the discharging service or discharging physician was. So just wanted to point out that you could even take the strategic level to be at a higher level to say no reimbursement penalty for readmissions, and then approach it from more of a process standpoint as well.
Please.
Sorry, go ahead.
I was just going to say this is fantastic. Please keep going if you had some other comments.
Okay. Well, I was going to see if John wanted to continue, or time-wise, what you guys, what we have available. He can continue to go through the specific deliverables and tasks if that's helpful.
Maybe pick another one. The bowel example was just very, very rich and shows such a connection between the strategic outcome, right, and root cause analysis, and then developing the specific protocols and cross-setting collaboration that needed to exist in order to make that happen. What a wonderful, wonderful example. Do you want to pick one other example of a task that any of these other tasks that come to mind, John?
Yeah, sure. So for maybe we could go to, there's actually quite a bit of the reporting tasks on here. So data obviously is very important. So maybe speaking to that best practice alert that's firing for the ED physicians, it's great that we put that in place, but and it kind of gives them a reminder, but you want to be able to report on that, right? So to determine how effective it's actually being, we're working with our IT group now to develop a monthly report for these surgery consults, and actually specific to this best practice alert to see how often it's firing, and then what are the different responses from the physicians, because they have to click yes, I'm going to follow up with the surgeon, or no, I'm not. So depending on what they click, we can see how often that's happening, and then actually separate from, well, maybe a separate I guess data piece from that, but pulling this into the same report. Did they actually order a consult? So we could go through and look at the orders specific to these patients and see if the surgery consult was actually ordered. So
great.
That along with putting a new process in place, you want to be able to measure the efficacy of it. So we need to work with our analytics group and develop a monthly report to show what is the actual compliance with this new process that we've implemented.
Yeah, and to that point, I think any improvement that we make, we always need to have that accountability piece in it. So if we change a process and then we're not, one, measuring to see how well are we adhering to the new process, but then even if we are measuring it, if no one is ever really asking, so, how are we doing? I've given the example recently in the hospital of, we were sending data, a report to a unit on their compliance with some characteristics, some measure, but I said, if we just constantly send data, but we never ask the manager for that area about the data, then you lose that piece of accountability, because if you as a manager constantly receive reports but you are never asked about the outcomes or the information in that report, then you kind of self-prioritize and say, well, this must not be important. So as we went through this, we tried to build in some accountability pieces as well.
This is fantastic. Thank you for sharing this. I'm sure we might. Oh, great. Thanks. Betsy's stimulating us all to chat in any questions that you might have. And I just wanted to kind of emphasize what I've learned. First of all, love the 5-level strategy map. I've never seen this tool before, but it just makes so much sense. It's so complementary to that driver diagram model. But really, there's additional utility here that I think is really great. And it really, what I see jumping out is of course the aim, and what this 5-level map does that we're learning here is there's the strategic outcome aim and the business outcome aim. And so sometimes on a driver diagram, I've noticed that teams don't know, well, should we say this is about patient quality, good care transitions, but then I'll turn around and I'll say, well, no, it can't just be about good care transitions, because you need something measurable, right, which is the reduced readmission. And so in a driver diagram, I often find a little bit at odds with what might be considered here on the map a strategic priority with a business priority, if you will. So I find those two levels very informative. In addition, we can see that the team, with regard to this particular focus on hip and knee, is embracing, the need for data, notifications, root cause analysis, alerts and notifications, cross-continuum collaboration with, on the bowel protocol example, as well as interdepartmental collaboration, especially with the ED ortho consult example here. So there's so much richness here. And then to Paul's observation that, hey, wait a second, this is what we developed for hip and knee, but gosh, it could apply to surgical patients in general. It could apply even to all readmissions, you know, with some of these action steps in terms of notifying the discharging attending, etc. So I think the example that once you get something like this on paper, Paul, you know, saw, gosh, we could generalize some of these principles here to readmission reduction in general. I think that's just such a fantastic lesson for us all to take away. So thank you so much. We'll look forward to seeing if there are further questions at the end of the session. I'd like to turn now to our second example provided by Kendra Cooper, who's the System Director of Quality and Outcomes for the Riverside Health System. So Kendra, I will turn it over to you.
Very good, thank you. Go ahead and advance it to the next slide. I want to make sure everybody can hear me okay as well. So just briefly, very good. Riverside Health System is located in Southeast Virginia, community-based nonprofit health system. And we are divided into 3 divisions with 45% of our business in acute care with 5 hospitals and 3 specialty hospitals. And then we also have a large medical group as well as lifelong health services with 10 nursing homes, also some PACE centers, home health, and much more. But really just showing you that from a complexity standpoint, which I'm sure many listeners today have as well, in terms of what all needs to be considered in the continuum. So next slide. And we've had you know, many informal efforts for reducing readmission, but in April of 2014, we're looking to something to kind of help us frame our work and formalize it, if you will. So while I've listed 5 steps here, we all know that it's not as easy as 5 steps. So I'll kind of speak to this slide and add a little bit more to it, and then I'll provide you some of the examples that we use. So as mentioned in April of 2014, we developed a readmission committee. So we have a steering committee that involved people from each of these divisions. We had an executive sponsor in Dr. Kyle Allen. And then I have a process improvement background as well as a clinical background. And I partnered to lead the co-steering of the committee with Melody Livengood, who is with care management. So kind of combining that care management background as well as quality. And so what we did in looking at this first step is a driver diagram. With a process improvement background, I was familiar with those, and also through our partnership with Premier in doing collaborative efforts, they use those as well. So we kind of scanned the environment to see what driver diagrams existed for readmissions and landed on one from Partnership for Patients as well as Premier, and I'll show you those examples in a second. And then we also just kind of took those components from for the combined driver diagram and did our own internal gap analysis. So kind of figuring out, we don't know what you don't know. And so with these many divisions, we wanted to make sure we were having synergy for our actions and trying to discover, what we have. So I'll show you the examples of that inventory that we did. I wish we had Dr. Botwell's tool at the time. So you'll see our rudimentary effort of the Excel spreadsheet. And then we developed, from that gap, we did 2 things. So for understanding our readmission data, since there were so many different methodologies and data sources, we really felt like we needed a team to look at all the data that's available and understanding which methodology is appropriate to use and when. So that was called our Data Information Source Team, or DIS. And then if we had any gaps that we needed to address from our inventory, we developed a Driver Action Team, or DAT. So we were kind of wanted to make it fun because there's always a lot of efforts going on. So we have DIS and DAT to reduce readmissions. So we had our driver action teams and our DIS teams then report back to the steering committee on a recurring basis of every 2 weeks to state how they were doing with implementing the specific action. So let's say doing a high-risk assessment. And then once that work was completed, which honestly took about over a year, we then worked to design and implement a sustainment checklist. So how will we know that those things that were put into place are still sustained? And to Paul's point about accountability. So I'll show you an example of that. And so some of you are probably familiar then with kind of the playbook concept these days. So what we did is took that framework and then localized it for ourselves. So that our team members would have different tools to relate back to and say, okay, I know Melody is the team lead for that, so I can go to her specifically, or you can go to this shared drive for these various reports. So then, again, that's very high level, so I'll just give you a glance at the different tools that we use. Next slide, please. And then you have to advance more time. It has animation to it, so very good. So this is the Premier driver diagram. And so while this one has more broad aim of reduce preventable readmissions, we fell along the Partnership for Patients to reduce it by 20%. And then we have those specific clinical focus groups, and then the primary drivers that are listed there, as well as a number of secondary drivers. And so this will be in the slide deck that you already have as a resource. Click one more time. And so then we also wanted to see, okay, this is what they have. So we wanted to look at other ones to see were there any other things that we wanted to add to it. So one of the ones that really wasn't listed to the extent we wanted was self-management skills. So then we went through these different drivers and change ideas to be able to do that. And then next slide. So with the combination of those two, created this Excel spreadsheet as our gap analysis tool. So putting that goal or the aim on the left-hand side, and then the broader category of using the process structures and the culture, and then what were the different resources that they were recommending, and then what program did we have in place to match that. So did we have a risk assessment tool in place at the time, and currently still actually, using a BRASS tool for risk assessment, and then each of these would have an owner assigned to them. And so, what cognitive assessment tools do we have in place? What's our patient education? What navigators do we have? So this was took more than an hour. It was actually a few meetings and several hours to kind of look at this, but it was helpful to inventory and know what gaps we had. Next slide. So this on the far left is just a little snippet from our playbook that we designed. So I just kind of wanted to show you reference back to the use of our driver diagrams to do the framework of our DIS and DAT and multi-stakeholder and system-wide efforts. So on that steering committee, folks from home health and our medical group, so we had a broader lens to look at our readmissions. And then off to the right-hand corner there, created a best practice checklist. And so what are the process changes that are expected? So each facility should have a readmission team. And with that, senior leadership attends. Then you have data analysis and the chart review. So what are the expected retrospective data elements that one might look at? Also, having interdisciplinary plans of care, what is to be discussed in those. Follow-up appointments and follow-up calls, so this is just kind of a partial listing. So then what we do is we have clinical close calls where our executive team will ask the different facility-based teams, where are we with this in place, not done, or will adopt. And most of this was during our implementation. So we also kind of go back and look and see, are we still doing these efforts. Next slide. So this is an example of a report out that we would do to executive leadership and others just to update. So we would say readmission interviews. So these were on the driver action teams. So it's now live at all of our acute care facilities. Our risk stratification live at all facilities. In terms of medication reconciliation, we used a pharmacy tech in our emergency department. So just kind of going through that, and so having that discipline to be on top of what each of the driver action teams are doing. LLH stands for our lifelong health. So what are the tools that they're using so we can have that relationship across the continuum as well as our medical group. And so if we were having a problem with follow-up appointments, then we can work with our medical group to problem solve for that. And some of our pieces that we're doing now, since many of these things are in place, so what we've done is sort of transition, and we don't do the every 2-week report out, but we have a steering committee, and each steering committee member is a liaison to one of our facility-based teams to make sure that they are on track, or if they have any questions or clarifications on the readmission playbook. And we also are emphasizing the VHHA collaborative, Omens the Hub, and also a webinar series looking at reducing avoidable admissions, so more from the post-acute side. And then, as you can imagine, there are transitions of care as well as transition of team members, so it's an active document to have our playbook. So that's a very high-level speed dating kind of a view of our efforts, and happy to take any questions.
Oh, thank you so much, Kendra. There's so much richness here in your work, and again, as you mentioned several times, and Paul mentioned as well, this reflects work as it's evolved over years, and so appreciate that journey. I really find very exciting. First of all, very clever, and it is important to have fun have fun in this readmission work, but with the DIS and the DAT team, and I find it particularly useful to think about creating those two teams, the folks that are focused on the data analysis work, as well as the more frontline clinical implementation work, and so that seems a particularly great idea for other colleagues to consider. And then I just think it's incredible how much synergy there is between what Riverside Health System has done in terms of scanning the environment, and what I thought was particularly clever that others might do is scan other driver diagrams or strategic maps. There are plenty of resources actually out there at this stage of the game. Kendra shared that Premier has a driver diagram. The Partnership for Patients has a driver diagram. The Aspire Toolkit has a driver diagram. The Maryland Readmissions Playbook has a driver diagram. You can find this information online, and so some teams may say, let's start with a blank whiteboard and let's brainstorm ourselves. But I thought it was particularly interesting idea to say, well, you could also scan to see existing readmission driver diagrams. Pick the one that you find most relevant to you, and then do the work that Kendra described in terms of, and then what's a gap analysis and how do we flesh that out and build upon that. Another thing I thought was particularly helpful is the driver diagram does not assign accountability. And so what we heard from Paul, and we also saw in Kendra's visual, is to assign an accountability point to each of the tasks of those secondary drivers. And so taking it from what are we doing to then who is on point for reporting on the success of that implementation. You can see through this slide, as well as Kendra's prior slides, that there is no one readmission reduction activity. This is a portfolio of strategies that, as Kendra outlined, is continually reviewed for implementation fidelity, I suppose we could say. Are there any problems? Let's problem solve the problems in each of these domains to make sure that work in each of these domains is happening. And that's a fantastic example of a portfolio of strategies with then the management connection to it. So Kendra, thank you so much. And let me see. Oh, okay. I'm just seeing a message from Betsy about slide 27 that maybe it wasn't coming out clearly enough. So hopefully you'll be able to see all the slides if you download the deck as Betsy has instructed us. So Kendra, thank you so much. And we're looking in the chat box to see if you have any questions for Kendra or Paul or John. So at this point, let's come back together with a few recommendations. So I hope that you can see that that thinking about the readmission reduction related activities and inventorying and surveying and thinking about how they all complement each other is really important. In the process of doing so, I think we've heard from both of our, we have heard from both of our guest speakers today that number one is, what is the aim? On the strategic map, it's what's the strategic objective and the business objective. On the driver diagram, it's what's the primary aim on the driver diagram. What is the aim? We're reducing readmissions for whom? By how much? By when? What is the aim? The aim then lets us know whether or not the set of strategies and activities we have can reasonably be expected to achieve that aim. Let's just say, for example, you wanted to reduce readmissions or readmission penalties for your hospital, and you had a heart failure strategy and a COPD strategy, but your data root cause analysis shows that sepsis is a big cause of readmissions, and you have an issue with your hip knee replacement readmission penalties. Well, then of course you would use this opportunity to say, our goal is to minimize penalties, but we have a gap in in hip and knee, and we know, and we're either going to address or decide to strategically not address the question around sepsis readmissions, because do we think sepsis is going to get folded into the program in the future, or is this such a big issue for our value-based payment that we should address it now, etc. So what is the aim? What does your data show you? Thus, which target populations or which issues are you going to focus on? That leads to the actions, these secondary drivers or the tasks on the strategic map. What do we do in the service of improving care for certain target populations so that we can achieve our aim? So many teams, again, because as Kendra well said, teams, there's turnover in teams. This work is a journey over multiple years, and so this isn't a critique of where we are, but rather to say sometimes we have a bunch of readmission activities. We're doing teach back and med rec, and we attempt to make a few phone calls for a few patients, etc. And so you know what the activities are, but they're not connected necessarily in an aligned, robust strategy to a focus on target populations that's going to lead you to your aim, to achieving your aim. And so, so this is really an opportunity to think about: do you have a strategy that is driven by an aim and designed to meet that aim, or perhaps you're here at the bottom line and you have a bunch of activities and you're not sure if those activities can align and get you to that top level aim. Either way, working with these kind of tools should help you advance your work in 2017. This is just another example from that Aspire toolkit. So we've seen Paul and John's example, we've seen Kendra's example, and I wanted to share with you, oops, sorry, I can see something didn't, all of the text didn't come up, but this is an example from a Baltimore hospital that I worked with for the ARC guide, and this was their specific driver diagram and my apologies that some of the words are omitted. It would be available to you in that Aspire toolkit if you care to see the detail. Finally, we've heard from both teams, and again, I'm so excited because we did not actually plan the messages to be as aligned as they are, and so this is just a great reinforcement of the importance of having your goals and your strategies and your tactics articulated, but that is just the beginning of making that plan work. And we've heard from both teams how important it is to assign accountability, and John articulated for us how important it is to measure and provide feedback to that person with accountability, so that if we have a plan that says a certain group of patients is going to receive a certain number or types of services, well, we need to measure that and provide feedback, because that is the heart and soul of a continuous improvement process. And so just inspired by our colleagues' reminder that accountability, feedback, and continuous improvement is really the purpose of creating such a plan. I share with you here another set of tools from the Aspire guide, very, if you will, simplified examples, but hopefully reminds or paints a picture of what a perhaps straightforward, I don't mean it's easy, but straightforward type of an implementation dashboard might look like. And so I'll just walk you through this very briefly to paint a picture. So I use this dashboard with a cohort of 25 hospitals I'm working with here in Massachusetts, and every month we look at this. The number of discharges, and again, we've heard from Kendra, measuring readmissions. There are numerous ways of measuring readmissions under the sun. I focus on the adult non-OB population. So number of discharges for the hospital. Number of discharges in target population 1. So let's say you have a heart failure focus. How many patients were discharged who have heart failure? Sorry, and I correct myself. How many discharges were there that had a diagnosis of heart failure? Let's say you have a hip and knee focus. How many discharges were there in the hip and knee population? So then you can see the relative number, the absolute number, and the relative proportion of all discharges that are in your individual target populations, or there at the bottom line, the percent of all discharges that are target population discharges, and that's a percentage. This is really helpful in the sense that it provides perspective. Some teams are currently focused on about 5% of their discharges. Other teams are focused on about 30% of their discharges. So it's a huge variation, and again, that it all depends on what you're defining as a target population. You may define one target population as all discharges from med-surg, right? We want all discharges from med-surg to have a needs assessment, to have a post-discharge follow-up phone call, whatever the case may be. That may be your target population number 1. Your target population number 2 might be all discharges to a skilled nursing facility. And so again, that would be 15, 20, 25% of your adult discharges. And then you might have a disease-specific target population, all discharges with heart failure. That might be, more like 2% of your discharges. So it gives you a sense of how many discharges did we want to impact in absolute numbers, and what percent of all discharges do we have some sort of dedicated effort in terms of managing better. So that's the top bar. The bottom table is about implementation. So the number of discharges in target pop 1 that received whatever it is you wanted to do. I call that strategy 1. It might be a bundle of things. It might be a thing, an action. So an example would be number of discharges in target population 1 that received a post-discharge follow-up phone call within 2 days, or whatever whatever that strategy is. And you got to measure that. So how many received it? Okay, 122. What percentage of the target population received the strategy? And that's where you borrow from the top table to inform the bottom table. Well, 122 is a lot of great post-discharge contact, right? But then you have to put it in perspective. Is that 80% success, or is it 25% success? I don't know unless I put it into context of how many people are in fact in target population number 1. So again, you go through what did we do and what percent success did we have? What did we do? What percent success did we have? And that is very simple. There's nothing mathematically complicated about that. And that can then be your feedback to your owners of each of those target populations or strategies to say, okay, great, you got 122 timely follow-up phone calls done, but we had 500 discharges in that target pop this month. How can we problem solve this? Is 20% success good enough to get us our goal? Answer no. So we have to be, that's when you bring in your team, your frontline staff, your process improvement coaches to really problem solve if you have a performance issue. And then the example on the right-hand side is, again, just a simple run chart. Again, we had a vibrant discussion in our November meeting about how people are measuring and tracking and trending readmissions, and there was a great variety, as there always is. And my recommendation is really to track readmissions, readmissions the way you can measure it at your facility, readmissions month by month. More importantly, though, is to track readmissions for your target populations month by month. So in this example, and all of the shades of purple, and I do apologize, are not distinct enough. But the first dark purple bar is the readmission rate for the hospital. And again, remember, in my world, I talk about the adult non-OB population. Okay, so that would be the example of the hospital adult non-OB readmission rate, and it hovers down there around 10%. Okay, in this example. We then have light purple bar number 1, which is, oh, excuse me, I'm going to skip to that third purple line. We'll call it target pop number 1, you could see. Target population number 1, I'll just give you an example, are heart failure and COPD discharges. And we started real high, up at 24%, but we're implementing our transitional care strategies for that target population, and you can see that target population is coming down nice and steady month by month. Great progress for that target population. And so again, one would think that we would take the implementation dashboard on the left, and if we are implementing our strategies for a high percentage of target population patients, we would expect to see the run chart that we see for target pop number 1, a very consistent reduction because we have high implementation of the strategies. And then, of course, you do that for any other target populations you see, and you can see our target pop number 2 kind of stagnant. So that's really important because we may be implementing our strategies either unreliably or reliably, but no matter what, our outcomes are not changing. So that's food for thought. You either say, well, we need to either implement better, or what we're implementing is not effective, right? And then, of course, that's another cycle of PDSA. So this gives you insight when you track on a target population basis and a whole hospital basis. You'll be able to see success in some areas, flat lines in other areas, and you can see that no matter what, this model right now, this program right now is not robust enough to bend the trend on that hospital-wide readmission number, which is the hardest number to move. So this is in the guide, and I hope, again, it really aligns with what we've heard from our colleagues today in terms of articulating your strategy, assigning accountability, measuring implementation, and engaging in that continuous feedback, because really this work is not only about the good ideas and the best practices, but it's about consistent, continuous improvement. So with that, I'm looking to the chat box, and I'll ask Betsy if we have any questions. We have 1 or 2 minutes for questions if you'd like to do so now.
Thanks, Amy. I don't see any questions currently in the chat, but if anyone has called in over the phone line and would like to actually dialogue with our panelists or with Dr. Boutwell, you can raise your hand and I will unmute your line so you can ask your question, or you could submit them via the questions portal in the GoToWebinar platform.
Okay. Well, we are eager to support you in your work to reflect on where you stand at the end of 2016 and where you'd like to go in the new year. And again, that will be part of our deep dive series as we get started in the new year. So we welcome your questions from today's webinar. You can always be in touch with our team here at the VHHA. Thank you so much to Paul, John, and Kendra for sharing just the incredible work and the exceptional examples that you brought to us today. They were rich and really provide a great guiding guidepost for where we all might want to go in the new year. So with that, we thank you, as always, for your commitment to reducing readmissions, and I wish you happy holidays and look forward to seeing you in the new year. Have a great day.
And please remember to complete the very brief survey that will pop up when you close your browser as well. Thank you, everyone.
Do you have a sense of what